Welcome back to Pharmacology with Dr. Sokolow. And so now we're going to talk about the last two classes in this lecture on drugs for, that block the coagulation cascade or act on removing that fibrin clot. And the first class of agent that we're going to talk about are the antiplatelet drug. So let's start with the oral antiplatelet agent. And the most common one and the oldest one is aspirin. So aspirin, of course, it's also an anti-inflammatory drug, an antipyretic drug, but at low dose, aspirin has some antiplatelet effect. Like the low dose is between 75 milligram to 325 milligram. And the way aspirin works is by inhibiting this enzyme, the cyclooxygenase enzyme that is responsible for the synthesis of thromboxane A2 from arachidonic acid. And so thromboxane A2 is one of the factors that can activate the glycoprotein 2B3A receptors that are on the surface of the platelet. So does, ATP is also a factor that can activate those receptors. But in the case of aspirin, it's just going to inhibit the cyclooxygenase and therefore inhibit the activation of the receptors and inhibit the platelet aggregation. So also aspirin is one of the drugs that can bind irreversibly to the enzyme and inactivate that enzyme. And so that means that their effect is going to last the entire platelet lifetime. Of course, in a platelet, you have more than one copy of the enzyme, and not all of the copy of the enzyme are going to be inhibited. But the action of aspirin is going to last for the entire lifetime of the platelet. And then clinical use, so primary and secondary prevention of MI. So patients who are at risk of developing an MI or patients who survive an MI are going to be taking aspirin for life. And the efficacy is not in question. What is still debated is like the dosing. But you can see, the dose range between 75 and 225 milligram for the anti-aggregant, antiplatelet property. And this was, kind of the dosing of baby aspirin, even though aspirin is not prescribed in pediatric population anymore. And now it's been rebranded to the cardio aspirin for patients who need to take aspirin for primary and secondary prevention of MI. The next oral antiplatelet are the ADP antagonists with clopidogrel and prasugrel. So clopidogrel is a prodrug, so that means it has to be metabolized into the active. It has to be metabolized into an active metabolite. So clopidogrel itself has no effect, and it has to be metabolized into an active metabolite. But both clopidogrel and prasugrel have the same mechanism of action. They inhibit the binding of adenosine diphosphate, so ADP, to the ADP receptor on the platelet. So ADP is one of those factors that can activate the glycoprotein 2B3A receptors, and therefore if you inhibit their activation, you inhibit the platelet aggregation. The inhibition with prasugrel is more rapid and more reliable than with clopidogrel, and the reason why is because clopidogrel is a prodrug, and so prasugrel doesn't have to be metabolized into an active ingredient, into an active drug to be effective, and that's why it's more rapid. Now, in terms of clinical use, they may be slightly more effective than aspirin for MI, but they come with a cost, and that cost is important. And so that's why, aspirin is still the drug of choice for primary and secondary prevention of MI. Now, those agents are also used for secondary prevention of acute STEMI, non-STEMI, unstable angina, and PCI. This will be covered in the lecture with Dr. Strelo when we talk about hypercholesterolemia and treatment of STEMI and non-STEMI. And also, it's going to be prescribed to patients who are intolerant to aspirin, who has GI problem with aspirin. Adverse effect, like all the other anticoagulant and other drug acting on the coagulation cascade, these are at increased risk of bleeding. And also there is a black box warning for clopidogrel and for the poor CYP2C19 metabolizer, because since it's a prodrug, people who have slow metabolizer are going to convert clopidogrel into its active form at a slower rate than others, and therefore the antiplatelet effect is going to be reduced in those patients, and there is a risk of cardiovascular event. If you don't remember that concept, I'm sending you back to the lecture on principle. Now, the next drugs are the parenteral antiplatelet agents. So these are GP2B3A receptor antagonists. So they are going to act directly on the receptors. They are not acting on agents that are responsible for the activation of those receptors. They are direct antagonists of the receptor. The first one is eptifibatides. It's a small peptide that binds directly to those receptors. Tyrofibin, which was designed after the venom of a viper snake. And then the last one, it's a small antibody fragment. It's ABCXimab. So again, MAB monoclonal antibody. If you remember one of the tips I gave you, I think last week, when you see MAB, that means it's a monoclonal antibody. All three are used IV only, and they are direct receptor inhibitor. So this is like the final common pathway for platelet aggregation. So they are going to act faster than the oral medication, and also because they are given IV, they are really used in acute situation. So they're short-term use to prevent ischemia in patients with acute coronary syndrome, such as, unstable angina, non-STEMI, and STEMI. They are usually added to aspirin and heparin or low molecular weight heparin to reduce the risk of complication for percutaneous coronary intervention. But as you can imagine, they are very expensive, and also these are only used in acute care setting. Because of their potency, they have an increased risk of major bleeding, and there is also a risk of potential fatal hemorrhage. So they have to be used very carefully, and again, they are reserved for acute situation and emergency situation. And then the last class of agents are the thrombolytic drugs. So this is the last step, is the removal of the fibrin clot. And plasmin, if you remember, is the one that degrades the fibrin clot, and the precursor of plasmin is plasminogen. So the thrombolytic agent, they are IV medication, and they act by converting plasminogen into plasmin, and therefore activating the enzyme that digests the clot. There are different types. You have streptokinase, which was the prototype, and then alteplase and tenecteplase. Again, I underline like a common termination on those medications that will indicate that they are thrombolytic agents. They are recombinant plasminogen activators, and they are selective to the activation of plasminogen bound to fibrin into thrombi. They are very short half-life, so you see 5 minutes for alteplase, and then this one has a little bit longer half-life. And so this one, again, adverse effect, risk of bleeding. You can have some risk of hypersensitivity reaction or hypotension with streptokinase. And then clinical use, they are used in acute setting. They are used for acute MI, acute ischemic stroke, and the timing of using those agents is very important. So you see here for the MI, the door to needle time. So that means from the time that the patient starts his MI to the time that is injected with that drug should be less than 30 minutes to have a positive outcome. And for a stroke, it's within 3 hours from the onset of the symptoms for a beneficial effect. So very short, like windows to use those medication in order for those medication to be effective. And then they're also used for the treatment of pulmonary embolism and venous thromboembolism. And so that's it for the drug in this chapter. I hope you enjoyed, and I will see you in class for any question you may have.